Hi, everyone. Good morning, good afternoon, and very warm welcome to this webinar brought to you by the Lung Cancer Policy Network, focused on the earlier detection of lung cancer. This webinar will be running for around an hour and 30 minutes, and we hope that you're able to stay for the duration of the session. Just to briefly introduce myself, I'll be the moderator for today's session. My name is Helena Wilcox. I work with the Lung Cancer Policy Network Secretariat team based in the UK at the Health Policy Partnership. I'm very pleased today to be joined by many experts from around the world from a broad range of expertise in lung cancer, including many of our network members this afternoon. Just a few pieces of housekeeping before we get going. So firstly, hopefully you will have been made aware that this webinar today will be recorded. The recording will be shared on the Lung Cancer Policy Network's website in the coming weeks, so please do keep an eye out for that. If you have any questions, we'll be using the Q&A function on Zoom, which you can access at the bottom of your screen. And if you would like to use closed captions to listen to read along with what's happening in the webinar, there is a closed caption function at the bottom of your screen. And if you would like these captions to be translated, there is also an option for you to select a language that you'd like them to be translated on, so you can follow the proceedings of today. This webinar is taking place in Lung Cancer Awareness Month, where with the Lung Cancer Policy Network and the broader lung cancer community, we are focusing on raising awareness of the importance of early detection and how this can be achieved. Before we get started, for those who aren't familiar with the work of the Lung Cancer Policy Network, I wanted to give a very brief introduction. The Lung Cancer Policy Network is a global multidisciplinary alliance of expert stakeholders, including patient organisations and advocates, leading lung cancer experts from a range of different sectors and industry partners. We're very proud to have just over 90 members from across the global lung cancer community, and you can see the locations represented in our membership on the screen. And on the next slide, you can also get a brief snapshot of some of the organisations who are part of our membership too. The network focuses on delivering consensus-driven, expert-informed insights on the priority policy recommendations for improving lung cancer outcomes. A significant amount of our work focuses on early detection and lung cancer screening. And I won't read through all of the contents of this slide, but if you use the QR code and the links also being shared in the chat box, you'll be able to access our website to explore our freely available resources, including reports, practical tools around early detection and screening implementation. We also will soon be adding to this library of resources later this month as part of Lung Cancer Awareness Month, with a launch of a report focusing on the management of incidental pulmonary nodules as a part of early detection strategies, which we'll also be discussing with a couple of panelists today. On the next slide, I'll just quickly showcase before we dive into some of the presentations who will be speaking today. So as I mentioned earlier, we have a sort of broad array of experts from around the world with various expertise in lung cancer, some of whom are our network members. The kind of running of the session today will be that we will firstly have an introduction from Matthias Johansson, focused on introducing the need and the importance of early detection of lung cancer and the evidence base for the different strategies that are available. We'll then hear from the broader panelists, so Professor John Field, Tiffany Gowan, Lauren Pretorius, Dr. Luis Reyes, Dr. Lucia Viola, and Professor Panche Yang, and I'll introduce them more when we get to their presentations. And they will be sharing from all of the different settings and the different work that they're involved in, what exactly is taking place in their locations to achieve the early detection of lung cancer and some of the outcome shifts that they're observing through those efforts. And then we'll also move later on, after we've heard from each of our speakers, to a panel discussion. So please do, throughout the presentations, post your questions in the Q&A box so that we can put those to the panel. So our aim of our webinar really today is to showcase, to underscore the importance of early detection of lung cancer and to showcase from around the world the range of approaches that can be adopted to achieve this. and to highlight some of those different approaches and the need for those to be attuned to the different population needs and health systems that are in place around the world. So just to set the scene for this topic and for the rest of our discussions, I'm very pleased to introduce Dr. Matthias Johansson.
Thank you very much, Helena. I'm joining you today from Lyon, France, from the International Agency for Research on Cancer. I co-lead the risk assessment and early detection team here at IR together with Hilary Robbins. So lung cancer is by far the leading cause of cancer death worldwide. This figure shows the number of cases, the number of deaths caused by lung cancer every year is about 1.8 million, which is more than double the number for both colorectal, liver, breast, and so forth. So it's really a terrible diagnosis to have. Now, luckily, I should say, lung cancer is in many ways the perfect cancer to screen for. This figure shows here the survival rates by disease stage. So here on the right side of the slide, you can see that people who are diagnosed with stage 4 lung cancer, they have a very, very poor 1-year survival rate, whereas those people who are diagnosed at an early stage, they have much, much better survival rates, almost 90%. And this is over many, many different countries. And on top of that, if we look at the number of cases that are diagnosed in these different categories of stage, we see that the vast majority of them are diagnosed with late-stage disease. So if it's possible to shift the proportion of lung cancers that are currently diagnosed at a late stage to earlier stages, it should be possible to save a lot of lives. Now, of course, how do we find cancers early? Well, we screen for them. So when we screen for cancer, basically what we do is to look for cancer before a person has any symptoms. This is not the same as preventing it, but we call it secondary prevention. And the aim is, of course, to detect a cancer when it is at an earlier stage, when it's easier to treat, and more people, more patients would survive from this treatment. For lung cancer screening, we use low-dose computed tomography screens. It's a fairly rapid process. It allows the entire chest to be surveyed in a single breath, and it takes maybe 10 seconds. It's quite a low-risk radiation. It gives approximately the same amount of radiation as 1 year of environmental exposure to radiation. So it's a fairly low-risk, quick procedure. And this is just a figure of how it looks. And this is probably the figure that you would see in any presentation revolving CT screening. These are the two figures showing the death rates from lung cancer in the two major lung cancer randomized trials, screening randomized trials. Here on the left, we see that people who were screened with low-dose CT in the American NLST study that was published in 2011, they had about a 20% reduction in lung cancer mortality. On the right side, you see a more recent study that was conducted in the Benelux countries, the Nelson trial, which again shows a quite clear reduction in lung cancer mortality amongst the group who were screened with low-dose CT. And this has now been trialed in a number of different settings around the world. And most of these studies, they show a clear reduction in lung cancer mortality. So the question now is not really whether lung cancer screening works, but rather how to do it most effectively. Now, when it comes to, well, I should say this bit first, that based on all these different trials, lung cancer screening is sort of being implemented in many countries around the world. It's been implemented in the US for quite a few years. It's been slowly rolled down in a number of countries around the world. And there are a lot of implementation studies that are conducted both in high and middle income settings. And the Lung Cancer Policy Network provides an excellent sort of survey of where this is happening currently. Now, as it comes with any screening program, it has to balance the benefits and harms. And when I talk about harms of screening, I talk about false positives, the potential of overdiagnosis, overtreatment, diagnostic complications, stress and worry, not to mention the actual cost of the screening program. And this must be balanced against the primary benefit of screening, which is, of course, prevention of death from cancer. And as a general rule, then there's some exceptions to this rule, but as a general rule, the higher the risk someone has, the more likely they are to benefit from screening. For lung cancer, this has been really well described in the first NLST trial. So this is a trial where they screened people that were considered high risk, that had smoked a lot, 30 pack years. And here we could see that those, even in this group of high-risk people, those in the lowest risk group, they had almost no benefit of lung cancer screening. There were almost no deaths prevented in this category of people. Whereas the higher the risk, the more cases were saved from lung cancer death. So this illustrates the importance of focusing screening on people who are at high risk. For lung cancer, it's a bit of a specific situation for lung cancer. Now, in most settings around the world, they use some sort of smoking criterion to identify lung cancer. Here you can see that in the US, they use a 20-pack year criterion. In the UK, they use a risk model based approach. In Croatia, again, they use a 30-pack year, so a slightly higher risk threshold, as well as in Korea. So the issue here is that the current screening criteria that are used around the world, they still miss up to 50% of incident lung cancer. So these are, of course, patients that cannot benefit from lung cancer screening. And this leads me to the research that we are doing at IARC. So as I mentioned earlier, I lead the risk assessment and early detection team together with Hilary Robbins. And we do a lot of work where we first evaluate different types of tools to predict risk, to assess risk, to be used as screening eligibility criteria. And we also develop biomarkers to improve on current risk models. And I'm going to give you just a glimpse of these studies. So the material that we use typically come from the Lung Cancer Cohort Consortium, and this is quite a unique resource. It's composed of longitudinal cohorts. So these are big cohorts that have invited in total over 3 million study participants that are, for the most part, healthy upon recruitment, and then they follow them throughout time, and then some of them are diagnosed with different type of cancers. And this allows us to study different type of risk factors, biomarkers, and so forth, and whether they can actually predict cancer in a sort of an ideal setting. Within the Lung Cancer Cohort Consortium, there have been more than 70,000 incident lung cancer cases that have been diagnosed. Here you can just see a snapshot of all the studies that we've done to evaluate existing risk prediction tools, and I'm not going to go into the details of this. We've conducted this in different settings around the world. But just a short take-home message from these studies is that there are multiple lung cancer prediction models that can identify cases in a better way than some of the sort of discrete criteria that are currently being used. For the most part, these models work a little bit less well in Asian and US minority groups. So there's clearly more research that needs to be done to make the screening criteria or the risk models more effective in those populations. We have also developed a biomarker panel, and the purpose of this panel is to be used to assess lung cancer risk. And here's a snapshot from our discovery studies. We use proteomics technology to do this. And here on the left side, you can see what we call a volcano plot that highlights a lot of different markers that were positively associated with lung cancer risk in amongst these cohorts from the Lung Cancer Cohort Consortium. And on the right side, you can see a similar study that was led by Rei-Jin Hung, that was conducted in the context of CT screening studies. So these are not general risk markers, but they are more nodule malignancy markers for people who have already had CT. So what we did was to take information from both these discovery analysis. We took our favorite markers and we put them on a custom panel. And the purpose of this custom panel is then to allow us to assess risk both prior to screening to be used as a screening eligibility tool, as well as after screening to assess whether For instance, someone has a high-risk nodule and they should be subject to further investigation. Then we've used this panel to train a risk model. So again, we're using samples and study participants from the Lung Cancer Cohort Consortium. Here we defined a training set that includes 7 cohorts from around the world. And then we've also defined a validation set, so a set of samples and study participants that we can use to assess whether this risk model works. And then we've used this integral protein panel and measured the proteins on all these study participants. So we have some 1,700 lung cancer cases and almost 3,000 cohort representative controls. And the way that we've designed these studies is using this case cohort design, which allows us to mimic the background population. So it's sort of an ideal study setting to evaluate how this type of risk tool would actually work in practice. Just almost 2 months ago now, we finally settled on a final risk model. And this risk model includes age, it includes cigarette smoke per day, it includes the number of years someone has smoked, and it includes absolute concentrations of 13 individual protein markers. And whenever we do these studies, we always try to compare the performance of a risk prediction tool to the best available tool, if you like. And the risk model that has been most widely evaluated around the world is the PLCO-M 2012 model. And here you can see the risk discriminative performance of this. This is a curve, this is a so-called ROC curve that plots the false positive rate versus the true positive rates for different risk thresholds. And what you want to see is that another risk model should be higher than the PLCO model. Now, if we look at how this compares with current screening criteria, if we apply the USPSTF 2021, so these are the criteria, the 20-pack year criteria that are currently used in the US, we would identify approximately 63% of future lung cancer cases using these discrete screening criteria by screening about 25% of the total population. If we instead use the risk model, we would identify about 70% of future lung cancer cases. But if we instead apply our protein-based risk model, you can see that the performance is quite a bit higher than the PLCO model. We would be able to increase the sensitivity of screening eligibility criteria up to 85% without screening any more people. So this is quite promising results. And we're now looking at various ways to implement this protein-based risk model into screening practice. Now, what about people who haven't smoked before? So I wanted to show you this figure. This is a really interesting and controversial topic. I wanted to show you this picture to illustrate why this is tricky. So this figure shows the cumulative incidence within the Lung Cancer Cohort Consortium for individuals who are currently eligible in the US, so have more than 20 pack years in the light blue color here. People who have been smoking, but they have less than 20 pack years in the dark blue, and people who have never smoked before. So you can see here that people who are currently eligible in the US, who are currently considered high risk, they have a sort of a lifetime risk, if you like, of about 20% if they make it till 90 years old. The corresponding risk for people who are not eligible but who have had smoking exposure in the past is about 5%. And you can see that the never smokers here have a much lower risk. So it's a real challenge identifying those never smokers who have sufficiently high risk to benefit from screening. Having said that, we also see an interesting thing in the Asian populations, in that the people without smoking exposure, they do seem to have a substantially higher risk than the corresponding person in Europe and North America. So we've sort of asked the same question of whether it might be possible to use biomarkers to identify people at high risk also in never smokers. This again is still work that is underway. Here we can see our discovery analysis that identified in particular 2 proteins as sort of risk informative in never smokers. And we've thereafter tried to evaluate whether these proteins might actually be sufficient to identify someone who has never been exposed to smoking or never been actively smoked as high risk. And here we can see that if we build a risk model using these 2 protein biomarkers, we can see that those in the very, very highest risk category, so the top 99% in the green line here, they reach 1% 5-year risk right around after they turn 70 or just before if they're female. So, and 1% is a good threshold to sort of think about when we want to think about identifying people who might benefit from screening. So we can see that there will be, just based on this risk assessment tool, it would be very challenging to identify a lot of people without smoking exposure who would be at sufficiently high risk to benefit from screening. So in our thinking around this, we definitely need to combine different type of risk information, for instance, family history, secondhand smoke, air pollution, and perhaps risk markers. And perhaps then we will be able to identify some people who have never smoked who might benefit from lung cancer screening. So to summarize, in many ways, lung cancer is the perfect cancer to screen from. And it works, it really works. I mean, we can see that it's quite clear risk, sort of mortality reductions in high-risk people from LDCT screening. And now it's being rolled out around the world, and the uptake is slowly starting to increase. So I hope and I think that we're going to see some real impact on lung cancer mortality rates in the future owing to CT screening. But there are some challenges as well. And as I mentioned, there are a lot of individuals affected by lung cancer who are currently not eligible. And of course, we're doing research on this, and we think we have perhaps a tool that could help in this setting. It's an open research question how to identify individuals who never smoked who might benefit from lung cancer screening. But I think we're going to hear about this later as well during this webinar. A real challenge that I haven't really talked about is how to reach high-risk groups. This is a persistent challenge in almost any setting. And finally, there is a lot of other challenges that I haven't gone into, nodule management, implementation of artificial intelligence, how to manage the capacity of the health system, risk communication, smoking cessation, and the cost, and so forth. So, but I think some of these topics will be discussed during the webinar. So thank you very much. And I'd just like to thank my team here at IARC who has been involved in this research that I've been presenting. Thank you very much.
Thank you ever so much, Matthias. That was a perfect sort of scene setter. And as you said, many of these topics or the challenges and outstanding questions, our panelists are going to explore what's happening in their settings to address some of those challenges. I just wanted to also remind everyone watching today that you're very welcome to post your questions in the Q&A. That's the best way to get hold of us, and we'll be going into a discussion once we've heard from all of our speakers. So we'll welcome you back shortly, Matthias, and thank you for that fantastic introduction and laying out all of that evidence and what we should be looking out for in the discussions.
Thank you.
So I wanted to move next to hearing from the remaining speakers who've kindly joined us today. So they will be sharing from their own work in the settings that they're based in, the need for early detection strategies that are nationally appropriate, that sit alongside and also beyond LDCT screening. So we heard from Matthias that LDCT screening, there are some kind of outstanding challenges to make sure that everyone who is at highest risk of lung cancer can benefit from screening, and also that we are capturing all of those at higher risk through other early detection approaches. So to start us off, we are welcoming Tiffany Gowan, who is with the American College of Radiology. Unfortunately, she is unable to join us live today, but she has very kindly pre-recorded an introduction around raising awareness of lung cancer screening among eligible populations and healthcare professionals, drawing from the experience of the National Lung Cancer Screening Day, which takes place annually in the US and actually took place this last weekend. So I'll open the floor to Tiffany's pre-recorded presentation, and any questions that you do have, will ensure that we get those across to Tiffany and find a way to answer them while she isn't able to join us live.
Okay, so my name is Tiffany Gowan. I am the Director of Patient Care at the American College of Radiology. I'm very, very excited to be presenting today on the importance of healthcare provider training and awareness efforts to improve early detection, specifically in lung cancer, but overall early detection, we all know, saves life. So the first initiative that I'm going to go over, which some of you are very familiar with, is Lung Cancer Screening Day. So we piloted this program in 2022. We launched in September, which is extremely late for November. And we just wanted to see if there was any want or need to see if anybody really kind of got onto it. Well, it ended up being an extreme success to have 400 sites sign up in less than a month. We saw that, okay, we would get some support, and there was a need to increase awareness. So what this campaign is, it has three main goals. One is to raise awareness of early detection through regular lung screening, to reduce access disparities, and more importantly, to reduce stigma and celebrate patients who decide to get screened, no matter what their smoking history is or if there's current smoking status. We want to just make sure that they know that the screening is available and it's an option for them to have early detection and have better outcomes. So when we launched again in 2023, we ended up launching in June, so much earlier than September, and you can see that we had excellent outcomes. So this was last year outcomes. You can see that we ended up having 759 facilities in 47 states throughout the United States, including Puerto Rico. It was compared to 328 signups in 34 states on our 2022 pilot year. You can see the types of facilities that have signed up. So hospital systems, medical practice collaborations, comp cancer control programs, medical group practice, advocacy organizations, veterans health associations. I mean, we really hit all across the gambit, which was really what we wanted to do for National Lung Cancer Screening Day. We wanted to raise that awareness. So this year, every year, we really try to listen to what our supporters want and need. And we created a website, a dedicated website for National Lung Cancer Screening Day. And this is where everything is housed. This is a picture of the website that can be accessed. When sites sign up, they get access to all of our editable flyers, our media toolkit. It has candid posts for X, Instagram, copy paste. It's for healthcare centers as well as patients. So anybody can use this media toolkit. It's really wonderful. Cut and paste, make it your own, and spread the awareness of National Lung Cancer Screening Day. We've also included a lot of patient resources from some of our partners associations. We've included provider resources, so those providers who are having these conversations with the patient and getting them into screening, so they know what Lung Cancer Screening Day is. They're aware of the USPSTF criteria of what it is to be screened. And then we've also created a state gubernatorial proclamation guide, and it's a cut, paste, add your specific state's information, and then send it out to your governor, and how to get the support from the gubernatorial level and increase that awareness so we can get people screened, get state support, And it really helps create access and disparity, limit the disparity issue. So that is lungcancerscreeningday.org. We would love to take this international. And there's something else that I really, really want to stress about Lung Cancer Screening Day. There is no wrong way to participate. Anybody can participate. If you can't open on, for this year, it's November 9th. If you can't open, that's fine. Do something during the week. Do an educational session. Go out into your community and just spread awareness about lung cancer screening. Have a lunch and learn. Do a grand rounds for your screening center. There is no wrong way to participate. I just really want to drive that point home. Anybody can do it. Patients, providers, nurses, doesn't matter. All we want to do is create awareness. It's creating awareness to help these patients be knowledgeable about screening and their healthcare. It's really, really important to have that patient engagement and understanding of screening and how it helps them. So again, no wrong way to participate. We do ask that people do sign up. We do have to have numbers to show that it is something that is increasing, and that way we can continue to do this every single year. So please sign up. There's no wrong way to participate. Anything, everything is on the table. Please participate and spread the word. Spread the word so patients can be screened. And that brings me into my next point of patient engagement. So you see here, I have videos, just a couple of them. The ACR, the American College of Radiology, has created this series of patient-friendly animation videos to educate patients about image testing. So these videos contain content based on the patient family-centered summaries on the appropriateness criteria, and this ensures that all the information and the evidence-based and written is written in lay language. The goal for this animated videos are similar to any kind of our outreach. So answer common patient questions about imaging tests, direct patients seeking more information to the ACR appropriateness criteria, patient-friendly summaries that are all accessible on our website, and to provide a resource to help patients and physicians and have that engaged conversation and shared decision-making about any image testing that they may have questions about. That slide, okay. And in addition to these educational materials, they needed to be curated and delivered to foster the patient engagement while increasing the familiarity and reducing stigma. We have produced these videos in English and in Spanish, and these videos have been really used specifically in lung cancer screening to educate these patients. We know that a lot of patients are eligible and they just don't know that they're eligible and that the screening test is available. So a lot of screening centers have these playing in their waiting rooms. They have them playing where that patients maybe are getting changed. So if they're getting their mammogram, they could be playing around those areas and make them aware of other imaging tests that they may be eligible for. And our newest one that I'm really, really excited about is talking to loved ones about lung cancer screening. And this video shows two people, a husband and a wife, having a conversation about lung cancer screening. And the information that the woman had received during her mammogram. So it's really showing a different way to have this engaged conversation. And again, bringing the patients together and then having the patient engagement. All these are accessible on the ACR website, and you can download them and free feel to use them any way you want. All right. Okay, so the next point is how to engage the healthcare provider. So we created another series because we saw that there was a need to create these informational animated videos to enhance healthcare professionals on imaging and patient and family-centered care topics. These have been very, very successful in bringing awareness to campaigns very similar to Lung Cancer Screening Day, Pink and Pearls, and highlighting the appropriate ways to have conversations with patients about their health care. So bringing all these awareness campaigns being able to have these shared decision-making, patient-friendly conversations with their specific demographic of their patient, understanding what their patients need, having these different criteria for screening. Every criteria is different. So really being able to break it down. These videos are 1 minute and 30 seconds. We all know medical professionals are super, super busy. So they're just tiny snippets on big, impactful, awareness campaigns that they can highlight to their patients. And in addition to the campaigns, it's having those shared decision-making conversations, how to use non-stigmatizing language when they're talking to their patient, making sure that they are not having their patient's guard get put up by using certain language that they may not even be aware that could put their patient, just kind of shut down their patient. So again, these are all available for anybody who thinks they would be useful to put on their websites. You don't have to ask. We just really want to promote anything of patient engagement and patient family-centered care. So these are all available on the ACR website. So key takeaways from this presentation that I just want to kind of drive home. It is really important to engage the patient in their healthcare decision, and specifically for lung cancer screening. A lot of patients really have hesitation in talking to their physician because they're worried they'll be judged about their smoking history. This is an opportunity to celebrate the patient, have them become more a part of their healthcare and making these decisions to get screened, and that nobody's going to shake a finger at them and say that you should have never smoked or you should have never done this. Break down that stigma and bring them in, celebrate them, say great job. So really, really engaging the patients, celebrating them, and help them get to where they need to be in their journey as far as a new, healthier way of living. So elevating national campaigns to normalize screening and create awareness. We really are pointing to educate healthcare professionals on how to engage patients using the non-stigmatizing tactics and allow trusted relationships to be established. Having these great conversations really creates trust, and that way the patient will keep coming back. They'll be more engaged in their healthcare. It'll promote better way of living, maybe more healthier outcomes, healthier decisions. And then, of course, my near and dear to my heart is sign up for Lung Cancer Screening Day at lungcancerscreeningday.org. Spread the word. If you want to become a dissemination partner, go ahead and email me. We would love to have as many people disseminate the awareness. Sign up, do something, send me pictures. I would love to create a slideshow after Lung Cancer Screening Day of all the amazing things that people do to celebrate these patients who are being screened. So with that note, I'm going to give you my contact information because I'm not there live. So please, please, please feel free to email me, reach out, ask questions, sign up, whatever you need. I'm here to help. And I hope this was informative. And if you have any questions, again, tgowan@acr.org. And thank you so very much for having me today.
Wonderful. And I know from having conversations with Tiffany that she and her colleagues at ACR are also particularly keen to work with others from around the world on sort of sharing similar approaches for raising awareness of screening where screening programs exist. So please do get in touch. And also we do have a blog post about the National Screening Day on the Lung Cancer Policy Network's website if you'd like to learn more about the programme, and Tiffany's contact details are on the screen too. I'm now very pleased to share a pre-recorded presentation from Dr. Luis Reyes with the Memorial Cancer Institute in the US. Dr. Reyes has been able to join us live, so we'll join the Q&A, but has also pre-recorded this presentation just in case he had any difficulties joining this morning. So we'll go ahead and share the pre-record, and he'll join the panel discussion shortly. Dr. Reyes will be talking about the the incidental pulmonary nodule program that he has set up to as an additional pathway outside and alongside screening to detect lung cancer earlier. So I'll introduce Dr. Reyes' presentation.
Hi, good day, everybody. My name is Luis Reyes. I'm the medical director of Memorial Cancer Institute in Miami, Florida. I'm thoracic oncology by career. It's a pleasure to share with you about incidental pulmonary nodules. This is a very important topic because it's not well known everywhere. You know, as many of you knew, we have data from lung screening since 2011. Despite that good data that we have from America and Europe, in the United States, less than 10%, in some places less than 6% of the patients get lung cancer screening. With all the effort that we are doing, it's very frustrating to know how this percentage is moving very slowly. And at the same time, we don't want to wait 20 or 30 years to reach 80 or 90% because we have so many people affected in lung cancer. At least in the United States, we have 240,000 people every year, something that we need to change. That is why incidental pulmonary nodules, the basic difference is instead of waiting for the primary care to send the patient to the hospital or the healthcare facility to be screened, we do every week tons of CAT scans in our hospitals. For example, I work for a large hospital system, public healthcare system here in Miami, Florida. We have 6 hospitals. We do 300 CT scans of the chest every week for different reasons: car accidents, chest pain, esophagitis, gastritis. All of these patients that come to the ER, they get these CAT scans done, and it's good that they go home after the incident is solved. However, a lot of them have pulmonary nodules. We call incidental pulmonary nodules, 4, 5, 6 millimeter nodules that are of no interest at that moment because remember, the patient came from a chest pain, car accident, heart attack. So it's important that we follow these nodules. That's the nodules that we call incidental pulmonary nodules, that all of us have these nodules already registered and recorded in the CAT scans of the chest that we do for other reasons in our hospitals. So that is what is the program, is to review these nodules in these CAT scans. Basically, it's a lot of work because, for example, in our healthcare system, we do 300 CAT scans a week. It's very difficult for our nurse navigator to review 15,000 CAT scans a year. For that reason, we use artificial intelligence. We use artificial intelligence software to screen all of these incidental pulmonary nodules in the reports of all of these CAT scans to identify which ones are the high-risk nodules, medium risk, and low risk. And in that way, our screening navigator, our nurse, goes through these reports from the artificial intelligence software every week, and then we contact the patients, and then we contact the doctors, and then we offer to enroll them in our lung cancer screening program because they already had one CAT scan done, and they are going to need a follow-up CAT scan, especially the ones that have larger nodules, soon. That's why they need to enroll. So at the end of the day, with lung cancer screening, we enroll people in the program, and we follow them every year. With IPN is another way, another source of patients to be enrolled. But at the end of the day, from both sources of patients coming from primary care or coming from the incidental pulmonary nodule, we put them together in our lung cancer screening program. Once that they sign and enroll in the lung cancer screening program, the follow-up is the same as we do for the non-screening. Based on the risks, the patients are followed with CAT scans. To finish, I can say that we detect in our healthcare system 10 times more lung cancer with incidental pulmonary nodule than with the lung cancer screening traditional program. That's the experience in Miami, but I can tell you that in Tennessee, here in Baptist, Tennessee, in the United States, they detect 7 times more cancers with IPN compared with lung screening. Same experiences in Georgia and in other centers in the United States. That's why I think these IPN nodule programs are very important to detect lung cancer, and we need to implement. The cost of the program, the cost of the software is well covered by all the we call downstream revenue that we generate during the workup for these patients with lung cancer. Thank you very much for your attention today. We will be answering questions at the end.
Thank you, Dr. Reyes, and we're looking forward to having you join us live for the Q&A towards the end. I think that's a really great example from your work of how the incidental pulmonary nodule program can act as a complementary program to lung cancer screening efforts. Next, I'm very pleased to welcome Professor Panjie Yang from the National University of Taiwan, who is going to share about the screening program in Taiwan, and also introduce some of the risk factors that form the basis for the eligibility criteria in Taiwan, which I think is a fantastic build from Matthias's introductory presentation that we heard at the start. So welcome, Professor Yang. Thank you very much for joining us, and we're really looking forward to your presentation.
Hi, everyone. I'm PC Yang from Taiwan. It's my great pleasure to share with you the recent progress of our national lung cancer screening program. As you can see here, lung cancer is a leading cause of cancer mortality, and non-smoking lung cancer is increasing. It is estimated more than 30% of lung cancer patients, actually, they did not have smoking history. You look at the lung cancer patient in different region, you can find that actually Asia has the highest lung cancer burden in the world. Around 62% of lung cancer occur in Asia, and 63% of lung cancer mortality occur in Asia. Next slide. In most of the Asian countries, they have the quite similar smoking prevalence in men and in women. You can see here, this is the data from Taiwan. In men, the smoking prevalence in adult male is 24.4%, and in female, it's remained only around 3 to 5% in the past 20 years. So, but you look at the lung cancer patient, actually 2/3 of our lung cancer patient, actually they did not have smoking history. Only 1/3 of them, they have smoking history. And the stage distribution can see here, more than 50% of them are stage 4 disease. This epidemiologic characteristic is quite common in Korea, in Hong Kong, in most of the Eastern Asian country. Actually, in Korea and Hong Kong are the same. Lung cancer is the leading cause of cancer mortality in women in Korea and in Hong Kong, and the smoking prevalence in women is only around 3 to 5%, exactly the same. Next slide. Because based on the talent study, we found that the family history is a high risk. So we convinced our government to start a nationwide LDCT screening program from July 2022. You can see here, we are aiming to double the stage 1 disease and 5-year survival by 2030s. This is a biannual LDCT screening program for the high-risk subject. We include 2 populations: heavy smokers, 30 years, 50 to 74 years old. We changed to 20 years after 2024 because of the successful implementation of this program. And another group is lung cancer family history in non-smokers or light smokers. We tend to screen in female younger from 45 to 74 years old, and in men 50 to 74 years old. And you can see here, overall, we have already screened 129,000 subjects. And you can see here, the overall lung cancer detection rate is 1.2%, and 83.3% stage 0 to 1. And you look at the heavy smoker, the detection rate is only 0.8%, and 67.2% are stage 0 to 1. In those with lung cancer family history, especially in non-smokers, the lung cancer detection rate is 1.7%, and nearly 90% of them are stage 0 to 1. They have both risk factors. Heavy smoker and family history of lung cancer, the detection rate is 1.1%, and the 2.5% of stage 0 to 1. Next slide. If we stratify by the gender, you can see here in male heavy smoker, the overall detection rate is 0.7%, and 2/3 of them stage 0 to 1. And you look at the female, those with lung cancer family history, the lung cancer detection rate is 1.8%, and 90.5% are stage 0 to 1. So apparently, in those with lung cancer family history, especially in female gender, they seem to have higher risk compared to heavy smoker in men. Next slide. So before lung cancer screening, you can see in the right-hand side, 50% are stage 4 disease, and only 30% of them are stage 1 disease. And by LDCT lung cancer screening, you can see here we increase the stage 1 disease from 30% to 74%, and the stage 4 disease decreased from 50% to 7%. We all know that the stage 4 disease is associated with very poor survival, and in stage 1 disease, the 5-year survival can be up to 85 to 90%. So by this way, we can effectively reduce the advanced disease, and we can predict that we can reduce lung cancer deaths by 53%. Thanks for your attention. Thanks.
Thank you very much, Professor Yang. I think it's such a fantastic example of recognizing that the risk and eligibility basis for screening programs. It's so important that they're tailored according to the local data and what you've observed. So it's such a fantastic example. Thank you for sharing some of those more recent results. Our next presentation, I'm very pleased to introduce Lauren Pretorius from Campaigning for Cancer, based in South Africa, who's going to speak about some of the sort of policy and advocacy efforts for lung cancer in South Africa. And just before I do pass over to Lauren, just a reminder that you are very welcome to share your questions in the Q&A box, and we will have time for the panel to put some questions to the panel towards the end. And if we don't get a chance to get to your questions, we will make sure to follow up with your questions with the panel in writing on our website afterwards. So I'm very pleased to introduce Lauren, and thank you for joining us and taking the time to share your perspectives from South Africa and across the region.
Thank you so much, Helena, and thank you to everyone for joining us today. So I'm going to start off by framing this and saying that South Africa does not have a screening policy for lung cancer at this moment. Recently, the clinical guidelines policy was adopted at the end of 2023 and has been sent into provinces. But I think what we want to look at today is to understand, and my message to those policymakers and experts that are trying to guide advocacy and research in countries like South Africa, which is low to middle income, is understanding what the health system looks like. In South Africa, we have quite a complicated health system. We have effectively two health systems, a public sector that is from general tax revenue and a private sector, and never shall the two meet. Patients that have private healthcare pay insurance, and they are treated and taken in entirely different facilities, and it is paid for on guidelines and protocols and medicine lists and formularies that are completely separate to what is the national. Again, on this, you have to also look in the public sector that we're looking at the screening. And the one thing here, though, is by law, is that the medical schemes, the insurance, are not required to provide screening for their members. By law, they're not required to do that. That should be the job of the public sector, which is quite in contrast to what it is. However, a lot of the private sector have introduced screening benefits, but not screening mandates or requirements. If we go down to the next slide, you can see why this makes a difference is because in South Africa, 85% of the population sits in the public sector. So only 16% of that population is covered in the private sector. If we go down to the next slide, we have to start looking at what are some of the issues that affect lung cancer care. And in a consensus study taken in Gauteng, which is the biggest economic province in the country, we see that there's lack of awareness about lung cancer in the communities and signs and symptoms, and there's lots of myths. We have a challenge in public health facilities where we're looking at public health and nurses and primary health care nurses that do not have a knowledge of it. And we're looking at problems where we're having inadequate diagnostic resources from a facility point of view as well as a machinery point of view. And then again, when we're looking at capacity on treatment, we're seeing that patients are seeing huge delays. These are all some of the problems that we look at. If we go to the next slide, I want to just highlight, this is the availability on the essential medicines list of what is available to lung cancer patients in the state. It's not in the private sector. Private sector have access to TKIs and to various other innovative products, but this is what is happening in the state. And the reason I show you this is to go back to the idea of what are we looking at if we start screening people in a country like South Africa and introduce a country like South Africa, and we screen, and this is what they're treated with. We're then enhancing stigma that says that cancer is a killer, that cancer is a death sentence. So there's a fine line that we look at it. So if we go to the next slide, we as advocates have come up with the 3 focus areas, and the National Cancer Framework from 2017 states that lung cancer is a priority for the government, but that screening is not appropriate. Large screening is not appropriate. If we look at the 3 focus areas, one of the major issues that are coming out here is if we first need to start educating our primary healthcare workers. In South Africa, we have an immense burden of TB, and those health workers are trained on that, but they haven't been trained in any other lung conditions, and we need to start looking in that. Again, we also have the mining sector, which is not very well explored within South Africa, on understanding what is the impact of communities around the mines on their needs. And if we look at the national treatment guidelines, one of the things that were published in 2013, there is mention made that because of the high incidence of TB in the country, there might be cause for overscreening, as well as while there exists an algorithm, that algorithm actually asks for only inspection of nodules greater than 6 centimeters. They also say in the policy that while there has been information and research on the effectiveness and cost effectiveness and the need for screening, that this is not recommended in middle income countries like South Africa. And in fact, that countries in high income countries haven't even taken up the mass screening. So this is something that we as advocates are dealing with when it comes to advocating for what do we do to ensure that there are better health outcomes for South Africans. a major thing, what we also want to look at is how do we start increasing and using the focuses of TB and the work that's being done internationally on TB and through grant-making facilities into South Africa. How do we increase that into include lung cancer? So these are some of the things. But I think today my message is that when we start talking about advocacy and policy and how we're creating that, idealism is not going to work in situations like South Africa. We need to make plans for places like South Africa that have all these issues and that have these complex healthcare systems so that we can start impacting patients on the ground. Thank you very much.
Thank you very much, Laura, and I think that's such an important message that others can learn from as well in terms of how to ensure that action is being taken in an appropriate way, even in settings where screening might, at least in the short term, might not be the most appropriate answer. So we'll look forward to welcoming you back shortly from the panel for the panel discussion. So next, I'm very pleased to welcome Dr. Lucia Viola, who is based at Fundación Neumológica Colombia, and she's going to speak about the kind of dual approach that's being taken in her work around screening and managing incidental pulmonary nodules. So thank you, Dr. Viola, and very, very warm welcome to you today.
Thank you, dear Helena, and thank you to the Lung Cancer Policy Network for this invitation. Here I am today to talk to you about lung cancer screening initiatives in Latin America and what we are doing here for getting objectives like having earlier lung cancer diagnosis. We have published this kind of consensus. This is from the Argentine group, and it's a consensus about recommendations for lung cancer screening programs in Argentina. This was published in the British Medical Journal, and it's important because it's important for the rest of Latin America, because here we can notice the difference between each countries. For Argentina, is very important to take patients with high risk given by tobacco exposure, because they have high tobacco exposure prevalence in their country. And they follow the same recommendations that the USPS task force in the United States. And they choose, for example, the population older than 55 years and until 74 years, and a history of smoking more than 30 years. And they established that the implementation, the lung cancer screening with low-dose CT must be done every year by the interval. The program characteristics for them is to have a multidisciplinary committee of professionals, and they also have pre-established protocols for decision-making about the lung nodule management. The next. But for the rest of Latin America, it could be different. This is another article that our group here in Latin America published this year. And what we do here is to give some tips for the standardization of minimal requirement for the implementation and formation of an early detection center for lung cancer in each country. We give here some advice about the population that must be taken to low-dose CT, the interval, and also we give, for us, we previous to this publication, we did a poll in the Latin America thoracic society. And what we noticed is that it was important for them to know how to do the low-dose CT, how to know that the CT scan must be the same that they use every day for for a pulmonary embolus diagnosis, or for a CT scan for other indications, but they didn't know that. What we did here was to give some tips about the low dose CT scans, to have routes for each person, for each institution, to know what was the epidemiology of their countries, to know what to do when you find a low nodule, and also to give education to the public, to other physicians, particularly the physicians from the primary care, and also to have a very secure way to recollect or to have information and to keep it available for research, and to show them to the other countries which are in the path to build their lung cancer screening programs. But next, here I'm gonna show you some cases from our clinic. This is a female, 52 years, and she had a history of lung cancer at very young age, at 24 years old, and she received treatment in a hospital here in Bogota, but she didn't have a follow-up because the people didn't understand that at that very young age she was diagnosed with lung cancer. Next. This is another patient from our clinic. She's a woman, 79 years old. She had this lung nodule, but she didn't receive advice about the need of following this lesion in the time. And when she came back a few years ago, the nodule was more solid and bigger, and she received also a lung cancer diagnosis. Next. Here we have another case. This is a woman, 67 years old. She had COVID-19 during the pandemic. Here we have some changes related to this infection. She also didn't know that a lung nodule was found in a CT scan during the pneumonia, but she started to have cough, shortness of breath, because of the pulmonary consequences of the pneumonia. And when she came to our clinic, we discovered this pulmonary nodule, but reviewing the previous CT scans, she had it during the infection in the pandemic. Next one, she also received a lung cancer diagnosis. Here we have another case. This is a 60 years old woman with this pulmonary nodule. She also received a lung cancer diagnosis in the next days after we had access to the lung biopsy. Next. Here we have also a case, 76 years old woman with this pulmonary lesion, which was an adenocarcinoma too. Next. Here we have another case. This is elderly woman, 86 years old, and she also had a lung cancer diagnosis. Next. Here we have another case. This is an elderly, also woman, 85 years old, with this pulmonary mass, and she also received a lung cancer diagnosis. Next. Here we have another case. This is a female, also 49 years old, and she received also a lung cancer diagnosis. She was to the doctors many times because of cough and also chest pain. Next one. Here we have a very young woman. She's 42 years old, and she was going also to the doctor for many years because of the cough. And we can see here in the CT scan with this big pulmonary mass, and also the bones compromised by the lung cancer. Next one. Here we have another case. This is a 78 years old female with this pulmonary nodule, which was in a previous CT scan 5 years ago, but it was, she didn't smoke. It was almost impossible that she could have lung cancer, and she didn't receive any follow-up of this. What we have here are the cases from our pulmonary nodule clinic, and all these female patients didn't smoke, and that's what's happening here in Latin America, because in some of our countries, smoking history is not as important as it is in the United States or maybe in Europe, because here we don't recognize, or we cannot identify the risk factor associated with the lung cancer diagnosis. This is the structure of our route in the hospital. We have now more than 700 patients in follow-up. The pulmonary nodule, incidental pulmonary nodule clinic is the route that has the big amount of patients included, and almost all of our lung cancer diagnoses come from the incidental pulmonary nodule clinic. Next. But sorry, can you come back? But we also have the lung cancer screening program, the lung cancer diagnosis and staging, the lung cancer and other thoracic tumors follow-up, and the tobacco cessation program is included in the other routes too. Next. And this is next. So thank you. This is the information about our center. Here we have diagnosis at stage 0 to 2 in the 32% of our patients. What we have here in our country is that less than 7% of our patients are diagnosed with lung cancer at early stages. Here we have a government way to also to measure this, because it's called high cost account, and what they have showed us recently is that less than 10% of the lung cancer cases here in Colombia have a early diagnosis. And what we do know about the CDC in the United States from data from 2020 is that 27% of the cases are diagnosed in the early stages. And what we have noticed, even though that we would like to have earlier diagnosis and less metastatic disease, we think that what we have been doing very well is to have an incidental pulmonary nodule clinic, because that's the way that we are getting these results. This data is gonna be, it was presented at the World Conference of Lung Cancer in San Diego past September, and I hope this information could be useful for you guys. Thank you so much, and again, many thanks for being here today.
Thank you so much, Lucia. I think that's such a great example, particularly the diagram that you showed at the end of towards the end of your presentation around how the sort of screening, nodule management, and other initiatives such as smoking cessation can all be integrated together within a kind of more comprehensive, overarching early detection and lung cancer management approach. We have around 15 minutes left of the webinar, and I think for sort of the richness of presentations means that our Q&A may be a little condensed towards the end. We do have one more presentation, which is Professor Field, who I'll introduce in a moment. We just wanted to say thank you so much for the audience members who shared questions in the Q&A. We will do our best to get through them and to get to them, but we will also work with the panelists to make sure that we can respond to your questions on our website in the next couple of weeks. So if we don't get to your question, then please do be reassured that we'll get an answer for you and a discussion going, and then we'll share that blog post with you once it's available. So I'm very pleased to welcome our final presenter, Professor John Field, based at the University of Liverpool in the UK, who is going to speak about the targeted lung health check programme in England, in particular some of the recent data around the impacts of the programme on those from different socioeconomic groups in England. So thank you so much, Professor Field, and we're looking forward to your presentation.
Thank you very much, Helena, for your introduction. As time is going through, I'll try to keep this relatively short. Okay, I'm going to give you an overview of what is happening in the targeted lung health check. But I want to bring, first of all, your attention to the Cheshire and Merseyside Cancer Alliance. I'm based on the west coast of England, and the Cheshire and Merseyside Cancer Alliance covers our area. And they actually, you can see at the very bottom, there's a press release, how Liverpool played a crucial role in the lung check programme. And what I show you at the top is, in fact, the UKLS lung cancer screening trial, which was published in 2017, and then the mortality data with a meta-analysis in 21. And in fact, I've also shown a press release. So basically, the UKLS was a major, let's say, turning point in undertaking lung cancer screening in the UK. Can I have the next slide, please? So the targeted lung health check was set up in 2019, and there were a group of over 20 of us that were part of that advisory group. So really, it's following the UKLS screening trial and 5 implementation programs that actually really provided the springboard for NHS England to launch the targeted lung health check. And it was open to individuals 55 to 74 years of age who had ever smoked. They were sent a letter to invite them, and if they passed the risk threshold using the LLP and the PLCO risk models, they were referred to a low-dose scan. So the LLP was developed in Liverpool as a risk model, and basically as they went through the implementation studies, some used one or both of these models, and it was found, in fact, they complemented each other, and it was decided to run both models. And I am the first person to say that no model is perfect. So I'm delighted they are using 2 models. Can we just move on the slide? Major point, June 2022, the UK National Screening Committee looked at all of the data that was available, the UKLS, the international data, and they made a recommendation that targeted screening for lung cancer should be undertaken in the 55 to 74 age group, being of high risk, and therefore using those 2 risk models. Then the next section, please. And the good news was last year, our Prime Minister, when celebrating 75 years of the NHS, indicated there would be a national lung cancer screening programme. Next slide. So where does all this take place? Start in 2019, there are now 75 sites. The majority of them actually have mobile units. I'm showing you a picture of the targeted lung health set mobiles at Birkenhead in Merseyside, which is my part of the world. And these have been very successful. Next slide. So one of the issues is, do we actually manage to target the deprived population? And this slide comes from the targeted lung health check group. And it's a breakdown of the life expectancy inequality gap between the most and the least deprived deciles in England, 2014-16. And you can actually see in the males, it's highlighted for lung cancer, and females, it's highlighted. And the likelihood of smoking is 4 times higher in England's most deprived areas than the least deprived. So this is the population that we really need to get to. Next slide, please. Next. But I want to go back. So I want to also give you some good news, and it's the impact of lung cancer screening on socioeconomic groups. Now, we use what's called IMD, which breaks down individuals, and we have used the quintiles. And you can see here Q1, 2, which are the most, should I say, the more deprived. And in the first box, you'll see on the left-hand side, lung cancer diagnosis. That red line is, in fact, the Q1, Q2 deprived community that had CT. And therefore, you can see how much they have gained from participating in the lung cancer screening. And you can see that we have 8 years follow-up. On the right-hand side, which we hadn't expected, is death due to COPD. And that blue line that is highlighted is, in fact, the control group within the lowest or the most deprived community, and therefore how much they have been impacted by COPD death and emphysema compared to the red line underneath. This was published in Lancet Regional Health this year. Next slide, please. So this is the data that's coming from the targeted lung health check. The early diagnosis rates for lung cancer has actually increased for all the deprivation quintiles post-pandemic, with the biggest gain seen amongst those living in the most deprived areas. And again, you can see I've shown this with a large red line. Next slide, please. So what we actually want to think of the key statistics. Over 5,000 lung cancers have now been identified in the targeted lung health check. And you can see that stage 1 is 62%, stage 2, 13%. So we are actually at 75% of early stage disease. There are over 75 sites are active, and over 900,000 people have attended the lung health check. Next slide. So this program is being rolled out nationally. You can see 24-25 working up to 28-29. 28-29, it is hoped that we will have covered 100% of the high-risk population in the whole of England. And then the whole program will then move into a rolling national screening program. So you can see that actually we are well on our way to actually implementing lung cancer screening as a national program in the UK. Next slide, or next part of this slide. This is something I wanted to show you. It just came out this week, and it was a news release from the NHS England, where more than 5,000 people in England have now been diagnosed through the targeted lung health check with lung cancer. And actually 500 of those are from my own area, the Cheshire and Merseyside. So in fact, we have made a major contribution. Unfortunately, we have a lot of people in the socioeconomic group that are, let's say, at the lower end. Next slide, please. So I want to thank all the individuals who have provided slides, especially Charlotte Smith, who's the program manager at the Target Lung Health Check in NHS. Thank you very much.
Thank you very much, Professor Field, and fantastic data and results that you were able to share with us today. I was hoping, I appreciate that some people may need to drop off, but just in the interest of having a short panel discussion, if our speakers might be able to lend us sort of an extra 10 to 15 minutes of their time, and I can welcome you all back on screen. Great. So we've had some questions from our audience. So I think I'll just start with a slightly more kind of general question. So I think across all of you, you've several of you have focused on the LDCT screening programs, and we've heard of several other efforts, including the sort of advocacy piece, awareness and management of incidental pulmonary nodules. Just as a kind of opening question, where screening isn't yet available, and as we heard from Lauren, might not currently be feasible, at least in the short term, what can health systems do to action early detection more swiftly, and how can we sort of see a pathway towards screening as the gold standard of early detection for lung cancer? Perhaps Dr. Reyes, if I came to you first, given you're sort of working across a couple of different nodes.
In the United States, the problem that we have is, we have this program, Medicare, that is the insurance for all seniors. And there are some guidelines that require screening. When you talk about mammograph and pap smear and all of these things, this is mandatory to the point that when you are evaluating your physicians, your primary cares everywhere in the nation, if you don't do one of these screenings, you are not considered to practice in good medicine. But Medicare has not implemented yet lung screening, even despite the fact that they pay for that. They have not implemented yet as a standard. So we cannot obligate the primary cares in the whole country to do screening. So that's one of the problems, among many others, because but I think that's one of the issues that we have, for example, in the United States. The data becomes mandatory by the government, the screening rates will increase tremendously.
Thank you, Dr. Reyes. Did anyone else want to come in on that point around how can we see a sort of pathway and stepwise approach to having a comprehensive early detection strategy, including screening? I'm not sure if Lucia and Lauren are online at the moment, if either of them wanted to comment.
Sorry, Helena, I'm having a little bit of an issue with my video for some reason.
Okay, no worries. We can hear you very well, so do go ahead.
So if you can hear me, that's fine. Yeah, I think that one of the issues is also, looking at how we integrate what's already happening and where the gaps are. In one of the things that we looked at in South Africa is the human resources that we look at. And that's something that's also got to be taken into account. So human resources, do we have enough radiologists in the country to do that, do the screening and so on? One of the biggest opportunities is where we can go from zero to hero is including that education in primary healthcare and making sure that those primary healthcare carers are able to identify the symptoms and refer quickly for a diagnosis or screening, and then a system that allows that. A lot of the time in South Africa, where we have this and similar countries, patients will get stuck in that rapid referral. So we're looking at that as well. How do we ensure that rapid referral happens?
Thank you. Did any of our other panelists want to comment further beyond what you've already highlighted in your presentations? No, I'll move on to some of the questions that we have from our audience. So just to start with, so question for Professor Yang. So you spoke a bit about the eligibility criteria, including those with a family history of lung cancer. Could you talk a bit more about the recommendations for screening family members? Are there different age criteria for those people compared to people with different risk profiles?
Yes, we screen those with family history of lung cancer start from 45 years old in female, 5 years younger than men. And if the index case means that the family member who had lung cancer, the age is younger, then we recommend that the subject need to screen earlier because they have same genetic background and also the environmental exposure. So we suggest that based on the index case age or index case, so we can lower down the age. And we screen so far is the first degree relatives.
Thank you. And also another question for you, Professor Yang, around the reductions in late-stage lung cancer. So are the reductions in late-stage lung cancer reflecting reductions in the population rate of stage 2 per 100,000 person years, or is it calculated based on the proportion of cases that are stage 2?
Yes, this is the first one.
The first
Yeah,
one.
actually, actually, you can see from the pie chart, in the stage 0 case, it's only around 6% to around 9%. Is no difference between the non-screening population and the screening population. So, but the stage 1 disease increased tremendously from 30% to 74%, and the stage 4 disease decreased from 50% to only around 7% now. Yeah.
Thank you. Perhaps we can move on to discuss a little bit around the management of incidentally detected nodules. So perhaps I can come to you, Lucia, first. So in your presentation, this is a question from the audience. In your presentation, you showed that a significant number of the patients come through this pathway. So what steps do you do to ensure that nodules are identified in the first place? And what is the stage shift that you're seeing from patients that come through that pathway rather than screening?
Well, the patients come from different different ways to the incidental pulmonary nodule. We have a cardiovascular hospital very close to our respiratory clinic. It's just crossing the street, and what we've been doing is training emergency doctors, thoracic surgeons, general surgeons, cardiologists, in identifying these pulmonary nodules that are found in other studies than the CT scans, thoracic CT scans. And for example, in a CT scan for the suspicious of pulmonary embolism, or in a patient with chest pain, and for example, in some CT scans from the urinary system, sometimes they identify the pulmonary nodules, and that's the way the patients come to our clinic from that source. But we also have other respiratory clinics which are not as big as the one where I am, and we also are trying to train some physicians, familiar medicine, internal medicine specialists, for example, and they come also from that source. And the way that we also giving education to the people, to regular population, people through social media, and also through the channels, the YouTube channel from the hospital, and also from the Facebook, Instagram, any of these sources. What we do is to give the patients the information about the need to follow up pulmonary nodules, because during the pandemic, for example, as I mentioned during the presentation, many of these patients they do have the pulmonary nodules. For example, the metastatic disease that we are diagnosing so far now in this moment, 2023 and 2024, when we try to get some CT scans from the past, most of the patients had, for example, a pneumonia or moderate to severe COVID-19, and they had a pulmonary nodule. And the pulmonary nodule didn't get any follow-up during all these years, because the patient wasn't tell that he needed or she needed a follow-up of this incidental finding.
Elena, I only want to add what Lucia is saying, that the incidental pulmonary nodule is challenging because a lot of people say that it costs money. But if you think about, you already have all of these CAT scans done in the radiology department of your emergency room or your hospital or your community area. The CAT scans are already done. What they need is somebody to review them and somebody to call the patients to tell them that they need a follow-up. That may cost some funds, but when you do this type of screening, we even, for example, told you, because it's a lot of work, we use in the United States artificial intelligence, and we pay a software for that. But when you call, I don't know, 300 patients because they need follow-up, and they need to do another CAT scan in a year, and then you need to do PET scan, then you need to do biopsy, then you need surgery because it's lung cancer, all of this downstream revenue can easily pay your small investment to have a nurse checking the pulmonary nodules or to have a software for them. Yeah, is 5 or 6 times more revenue generated for all of these procedures, including lung cancer therapy, than the investment that you do hiring a nurse to review your nodules or hiring or paying for the software. That's the important thing, because all of us have to fight with administrators that think that lung cancer screening is some sort of charity and now that we're asking more money. It cannot be like that. We need to do a cost analysis to show them that this is cost effective. And I think that will help a lot.
Thank you. And you did touch on the use of artificial intelligence in your program for the incidental nodule management. But I wondered if we could broaden that out a little to a general question to our panel about the role of AI assistance in the screening programs as well. I think obviously they're kind of looking through the same type of scans, the CT scans, but in an LDCT screening program, if anyone would be open to commenting on the kind of role of using AI to assist with the LDCT screening programs, scan interpretation.
Well, I'm happy to make a few comments. I mean, I think we're on the cusp of a wave of how we're going to change, but it has to be undertaken in a very organized way. The AI systems need to be assessed with current practice, and also the benefits that need to be identified. And I think the thing is that we can look at AI at a number of areas, assisting us in identifying high-risk individuals. And not everybody has, let's say, primary care data. They may be going and looking at different types of data sets. But once you've identified the individual, then the actual CT scan itself, how this can be assist the radiologist, how it can have an impact on the workload of the radiologist. But also, actually, when we're looking at the nodules, can we actually determine, let's say, malignancy potential within these nodules? So, if you have, let's say, an alert, do you wait another 3 months, 6 months, 12 months? In other words, how we actually follow these individuals up. So I think we are at that point where AI will have a major impact, but we will have to go through a lot of quality control and assessment before it's implemented.
Absolutely. Thank you, John. And indeed, that is the kind of focus of lots and lots of research at the moment to help answer some of those challenges and questions that you've raised. I wondered if we could maybe come back to something that Luis and Lucia have both touched on in your presentations around awareness, and perhaps, John, if I could come back to you around some of the awareness among the eligible population for screening, and how you've been trying to raise awareness of the screening opportunity of lung cancer itself, and also with the aim of achieving sort of higher uptake for screening, and what's been happening in the targeted lung health check to achieve that.
All right, so they have a very, let's say, active comms team. So it's different approaches in different populations. Writing the actual patient information sheets in a language, let's say, that they understand, bringing it back down to what you might say is day-to-day language. Also, one of the projects that we're involved in is actually how we can recruit from the non-responders. And just give you an example, we have actually sat down with community centers, shown them the primary, should I say, the patient information leaflets, which they said were far too long, far too complex, and can we put it into a simpler language? But one of the other areas is actually using QR codes on these documents. And most of these individuals do have smartphones. They can immediately go in and use Google Translate, so it'll be read out to them and in the language that they are most familiar with. But actually, even down to knocking on people's doors and informing them that in their region, the screening is now taking place. But also actually enrolling patients that have been recruited, and they may have said, well, I'm really glad I turned up, and they found something small, they've operated, and I now feel great. So I think that type of message that's coming from the local community, where individuals have participated and have been successfully treated, I think is a very powerful way forward. So all of those types of approaches are being included in the targeted lung health check.
Thank you so much. And as you highlighted in your presentation and your remarks just now, the importance of tailoring those two different communities, and also to make sure that you're adjusting with the people who aren't attending screening and understanding what some of those reasons might be and how that could be overcome. I'm conscious of time, and I appreciate very appreciative of the panelists for staying a little longer, and also the attendees for staying a little longer too. I wondered if, just before we welcome John to give some closing remarks, Matthias, if we could maybe draw the panel discussion to a close with you on sort of, from your perspective, the kind of priorities for early detection, taking a global perspective to see that stage shift and achieve that stage shift for lung cancer.
Yeah, I mean, it's really exciting times. I mean, we're seeing sort of CT screening rolling out across the world. I think the challenges that are faced in different settings are quite varied. I mean, sometimes we see health system challenges. Sometimes we see capacity of radiologists and so forth. And I think there will have to be a fair bit of sort of local knowledge and ingenuity that will have to go into making it work in each setting. I mean, we sort of know that it works. We know that it works in high risk settings in particular. I think a common topic now is sort of also reaching people who are currently not eligible and might be still at high risk for lung cancer. And there's a real, I don't know, it's a very active research topic. I just highlighted a bit of the research we're doing, and we'll see if this. I mean, the results that are coming out that Professor Young presented are absolutely fascinating. That they see sort of detection rates that are as high or higher in never smoking women than in heavy smoking men. It goes a little bit beyond of what we understand about lung cancer risk, and it's difficult to sort of see how this can be translated to different settings, because it goes a little bit against what we understand when it comes to lung cancer risk. But it's quite fascinating, and I'm looking forward to understanding that much better. Perhaps we can use biomarkers for that. We're doing some initial research suggesting that people are actually really quite interested in having their risk assessed using biomarkers, and perhaps that could also remove some of the stigma associated with being sort of accused of smoking heavily, for instance, in their lives. So there's a lot of different areas of research that will hopefully go into making lung cancer screening effective around the world.
Thank you very much. And yeah, it raised a few additional topics, particularly around acceptability of sort of personal understanding of personal risk. I'm sure we could have a whole hour-long discussion on that itself. But thank you for sharing those sort of final reflections. And with that, I will open the floor to Professor Field, who's very kindly agreed to spend a few minutes kind of reflecting on the discussions that we've had today, the topics that have been brought forth, and thinking about the sort of priorities for early detection and next steps in the policy space. So Professor Field, a few minutes for you to share your final thoughts.
Okay, thank you very much. I'd like to thank all my colleagues actually for excellent presentations. And actually they provided a great platform for discussing early detection. And from my point of view, the highlights of the webinar Matthias has talked in detail about the work they're doing in IARC, which is part of an NIH program. And the whole concept of actually developing risk models with protein biomarkers is actually, I feel, is the next step forward. And he actually mentioned the never smokers, which I'll come back to. Tiffany actually focused on the healthcare training that's being provided. And I really like the strapline, "The next life saved may be yours." I think that's a very, very strong message. And the great work that's around patient engagement and the videos they developed. Dr. Reyes actually gave a really excellent talk around these incidental pulmonary nodules. And I quite agree with him. Instead of waiting for the primary care to actually refer, why don't we actually utilize the CT scans that are taken on a regular basis? And he was indicating there's 15,000 in his area. And in fact, they're identifying 10 times more lung cancers. Now, I'm not sure if that's going to be right across the whole, let's say, globe, but it's something that we should consider, and the utilization of AI tools. And I know there's a number of AI tools out there that are more than capable of going back and looking at these images. Professor Yang actually has given a great talk around what's happening in Taiwan and the national program. And I'm not going to repeat all his data, but the detection rates of the non-smokers compared to the heavy smokers, and Matthias reflects on this too. I mean, we don't have a reason for it at all, and we don't have a biological reason for it. And the point that females with a family history, there was a 1.8% detection rate. So it demonstrates that actually we still have a great deal to learn. Lauren actually was talking about South Africa, and I actually felt that she took a very realistic approach, in so much that instead of saying we must introduce a lung cancer screening program, we actually need to educate our healthcare workers beyond TB, but actually utilizing the TB as a platform, maybe one can then actually introduce the whole concept of lung cancer and lung cancer screening. And one can actually understand there's a very different system based on insurance in the public sector and who is actually going to pay for the screening. But I think our final comment was they need a different plan for lung cancer screening in South Africa. And a great talk from Lucia of what's happening in Colombia. And she also was talking about IPNs, and also gave some great slides and great examples. And I think, unfortunately, some of these examples show the delayed diagnosis, individuals repeatedly going back and saying, I've got chest pain, I've got a cough, and they weren't referred. But also noted that many of the women with lung cancer were never smokers. So I think I'd like to sort of leave the final comment. We have made internationally an enormous effort to identify lung cancer in smokers. But we know 10%, maybe 15% of lung cancers are in never smokers, and naturally more in Asia. And I think that is the next great, should I say, academic clinical challenge of how we identify these. Now, I appreciate, and in the UK, lung cancer screening has been implemented because it was shown to be cost effective. So we need to demonstrate that actually identifying a high-risk population, it may be using biomarkers with various epidemiological and clinical tools to identify the high-risk individuals in the never smoking population. Thank you very much indeed, Alina, for putting on this webinar, and I hope people have gained from it. Thank you.
Thank you very much, Professor Field. So with that, I will draw the webinar to a close. Firstly, my sincere thanks to all of our speakers. I know Lauren has had to drop off as we've run slightly over time, but thank you ever so much for firstly your presentations and for your generosity of time in staying a little longer so that we could explore some of these topics in more detail in our panel discussion. And also thank you so much to everyone who joined the webinar and listened into the discussions and shared your questions. As I've said a couple of times, we will absolutely work with all of the speakers today to write these up and share our thoughts in a blog post on the network website. So if you've consented for us to contact you after the webinar, then you'll receive this, but if not, then look out on our website. This webinar is taking part in Lung Cancer Awareness Month. As a network, we have several activities, including this webinar and also a report launching later this month focused on the management of incidental pulmonary nodules. And many of our members are very, very active in the lung cancer community. So please do engage with Lung Cancer Awareness Month. You can access all of our resources focused on earlier detection and LDCT screening using the QR code that's on the screen. And you can also connect with the network on any of the forums that are listed on the right-hand side of the screen as well. So once again, thank you everyone ever so much for all of your time. It was a pleasure to spend the afternoon with you, and we look forward to speaking with all of you very soon, and have a good rest of your day. Thank you.